Welcome everyone to today's webinar entitled Falling Among Older Adults. What are the benefits of a fall prevention program? I'm Chris Danley, President of the National Physical Activity Society, and I'm hosting today's webinar. This monthly webinar series features topics for physical activity practitioners across a variety of settings. We hold webinars on the third Monday of each month, except January and February, when it is the second Monday. You can find recordings of our webinars, including this one, later this week at our website, physicalactivitysociety.org. You can also join our mailing list there and become a member. Our membership is free, and there's lots of benefits for membership. You will have the opportunity to submit text questions to today's presenters by typing your question into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. I'm very excited today to host this webinar on a program that's taking place in my own state of Idaho. I was particularly interested in showcasing this program due to the recent evaluation that our society did amongst practitioners throughout the country that demonstrated a need for such content. So, on with the show. Today's speakers. First up, Katie Lamansky. Katie is the Health Program Specialist for the Physical Activity and Nutrition Program in the Division of Public Health at the Idaho Department of Health and Welfare. Her primary role is providing oversight and management of the PHHS Block Grant, which funds Idaho's Fit and Fallproof exercise program. She also contributes time to the CDC 1305 grant activities, including overseeing statewide healthy child care initiatives and improving walkability in communities. Katie received her BS in health promotion at Boise State University. She is a mom of 2 little boys and an avid runner. You can find her frolicking, yes, frolicking, on trails in Boise's foothills or along the Greenbelt with her friends during long weekend runs. Also presenting today is Michelle Arnett. Michelle is a research associate and adjunct faculty with the Center for the Study of Aging in the Department of Community and Environmental Health at Boise State University. She was part of the research team that conducted a longitudinal study evaluating Fit and Fallproof, a fall prevention program for older adults in Idaho. Currently, she is part of a team conducting qualitative research exploring the impact of retirement on low to middle income women, as well as participating in several program evaluation projects with community partners. She holds a Master of Health Science from Boise State and a BS in Sport Management, Fitness and Wellness concentration from California University of Pennsylvania. And as a certified personal trainer with the American Council of Exercise, her clientele primarily has been older adults ranging from persons with functional limitations to triathletes. So, with that, let's go ahead and get started. Thank you, Katie and Michelle.
Thank you. Thanks, Chris. Can you guys hear me? Okay.
Yes, we can.
All right. And yes, I have been known to frolic in the foothills when the flowers bloom. That's kind of what I'm known for among my group of friends, so thank you for touching on that. And thank you for having us. We're excited to be able to present to you what we're doing in Idaho to address address falls and improving older adults' health and through exercise. And so we'll go ahead and take it away. Let's go ahead and switch.
No.
And our slides.
Of course, we get technical difficulties. There we go.
Okay. So what do we know about the older adult population right now? We know there are challenges among older adults. As they get older, they have challenges in staying physically and mentally healthy. So among the decreases in strength, flexibility, endurance, there can be walking problems, issues with the feet, the ankles, declines in vision, hearing impairments, and other chronic diseases that can impact their physical and mental well-being. In addition to the physical changes, there's also mental and emotional changes. Older adults experience grief or loss or feeling isolated. Oftentimes it's prevalent, particularly prevalent in our more rural communities. The feeling of isolation when the older adult loses friends and families who are close to them. Physical changes can also lead to the loss of independence, with potential moving away from their home, in with family, or into an assisted care setting, which can be a very difficult life change. Most adults will face some normal age-related changes, including those that affect physical activity levels, which may affect their lifestyle, and those may in turn impact their mental well-being. There are evidence-based programs that are taking place throughout the nation. Some of them you'll see on your slide today. These are all recognized as evidence-based programs that are designed to reduce falls. You can see a full list of these programs in the CDC's Fall Prevention Compendium, 3rd edition. Some of the interventions are multifaceted. They address environmental, behavioral, and physical risk factors. Yale Fix It and Stepping On are two of those examples. Others, such as Otago, are individually tailored exercise-based interventions that are led by a physical or occupational therapist. Some of them, such as Matter of Balance, are volunteer lay leader workshops with the goal of reducing the fear of falling and increasing activity levels among community-dwelling older adults. There's a review of the literature that reveals little information about sustained volunteer-led community-based programs in rural and frontier settings, such as Idaho. So why did we not choose one of those programs? Why not one of those programs here in Idaho? We have very rural as well as frontier geography in this state. We do know that frontier counties in Idaho generally have population estimates of less than 7 persons per square mile. Idaho as a whole averages about 15.6. This is back in 2009, that last estimate I found. About 15.6 people per square mile, where the U.S. averages about 79.6 persons per square mile. So you can see the vast difference in geography and population that we have here, that we have a very large state and about 1.6 million people spread out through that. So it's very difficult often to reach older adults in those very rural and frontier areas. So that's one of the reasons why we came up with an Idaho solution to support seniors. There is no other public health funding specifically supporting older adult health and independence in the state of Idaho. Transportation is also very irregular, expensive, and because of the sheer geography of Idaho, it's also very time-consuming. And lastly, we have a health professional shortage in this state, specifically in our rural communities. A health professional is a requirement to lead some of the evidence-based programs we previously mentioned. So offering an evidence-based program of some of the designs that we mentioned just a moment ago that require the health professional is costly, if not infeasible, in many of our rural communities. What we do know about Idaho is that, and also nationally, falling is a leading cause of unintentional injury and death among older adults. So about 85% of deaths from falls occurred among those 65 or older. Idaho's population is also aging at a faster rate than the nation. We know that people 65 and older increased roughly 19% between 2010 and 2014, compared with 14.2% for the United States during that same time period. In the United States today, those who are 65 and over comprise nearly 13% of the population, but in less than 25 years, that same age group will make up roughly 20% of the population. So you can see that shift in the demographics that's already taking place. And locally and nationally, we know that fall prevention is a public health priority. In Healthy People 2010, decreasing deaths from unintentional falls is a national health objective, and it's the objective that we use to base our program in Idaho for funding through the Preventive Health and Health Services Block Grant. So, Fit and Fallproof became Idaho's Fall Prevention Exercise Program, developed in 2004. It is a partnership between the state health departments and our local health districts. We have 7 health districts that oversee and manage this program at a local level. The program is volunteer-led, and the classes are based on a train-the-trainer model. Classes take place anywhere that seniors gather, senior centers, community centers, churches, libraries, throughout the community. Wherever there is an open space and available, you might find a Fit and Fallproof class there. So the department saw the need for this program to improve the health of seniors, and the Preventive Health and Health Services Block Grant, being flexible funding, provided us a way to sustain that program through this volunteer lay leader model. The public health districts reach all of the counties in Idaho, including our very rural and frontier regions, and volunteer leaders and classes reside in larger urban suburban areas, but especially in those rural areas that have few resources to meet older adults' needs. Just a description of the way the program works. So we have classes that last 45 to 60 minutes apiece, typically meeting 2 to 3 times a week. We ask that each session runs for 10 weeks. We do know that a lot of sites will just hold sessions ongoing. They might take records in 10-week spans of time and hold them throughout the year. But our ask is, because we know that the greatest muscle gains happen after 20 weeks, that an actual session is 20 weeks in length. And then our requirements for sites are they must hold a session 3 times per year. So here's a look at our model, our train-the-trainer model. So at the very top, we have our core master trainers. They are our individuals who worked with the department to develop the program. They're thankfully still with us and incredibly valuable to us. They teach our volunteer master trainers throughout the state. So they hold master trainer workshops. Those master trainers who are trained, in turn, teach our volunteer class leaders. And then we have our volunteer class leaders who teach the class, collect the data. Currently, we have 2 core master trainers. There are 7 local public health districts coordinators, and each of those 7 coordinators is a master trainer. And then we have 15 total master trainers between our 7 health district master trainers, as well as individuals that they have trained within their health districts. And we have more than 300 volunteer leaders. We have leaders being trained in every district every year. The volunteer really is the heart of Fit and Fallproof. So our local leaders are trained to teach the classes. The training is a whole one-day training. It's hosted by the health district, typically in partnership with the health district and one of their local master trainers. The volunteer trainers receive refresher trainings annually and ongoing support from the health district. So our health district coordinators provide site visits. They check in on them in person, via phone or email to make sure that they're doing okay. How is their class? Do they need supplies? So they receive that ongoing support from their local health district coordinator. They're also given encouragement and that social support. So the encouragement, again, with through recognition, annual recognition by the health district for their volunteer time, and then social support through through the cadre of other peer leaders in that region. So this is just a look at our curriculum. So we have the class leader training manual. It was just redone by Michelle and Jan and Terry Ann just in this last year, and it's beautiful. We have a very professional manual. We're excited. If you visit the website, it may or may not be up on the website. We just had it finalized and sent to our webmaster last week, so it may or may not be updated on our website yet, but I promise it will be up there soon if you're interested in looking at our curriculum. A couple other notes about the curriculum. It is based on evidence-based programs that similar to what we mentioned in a previous slide. It includes a warm-up, strength and balance exercises, and a cool-down. The program provides social and emotional engagement, which is important. Both of them are important for successful aging. The curriculum is, the exercises focus on functional fitness to improve balance, strength, flexibility, and endurance. Focuses on developing strength in legs, core, and hips, and reducing the risk and or severity of falls. This is just a look at some of the chapter titles from the manual. You can see what the role of Fit and Fallproof is in healthy aging, how to set up your class, knowing your participants, getting your class ready, ensuring safety and preventing injuries, teaching to the whole class. So rather than teaching in a more one-on-one personal training atmosphere, it's ensuring that our leaders know how to teach to multiple individuals with different teaching or different learning styles. There is an exercise directory and then some example class sequences at the end. So this is just a breakdown in our state of our 7 health districts. And you can see the number of sites. Right now there are around 117 or so sites. The retention rate of our participant population is around 85%. Michelle, do you have anything to add?
Yeah, ongoing, we collect this data every quarter. The different sites send in their class attendance sheets, and on that we record attendance, their timed up and go scores, which we'll talk about in a little bit. And so then at Boise State, we collect that data and run reports. And we also keep track of who is new and who is returning from each 10-week session. And it's been this way going back to 2012 when we started collecting this data at Boise State. Pretty much consistently, it runs between 83 and 87% return. And there's about, on average, 15% new each time a new session starts. And so having talked about this on the national level at different conferences, whenever I state that, jaws drop, because in any kind of exercise program, to have that kind of retention rate is pretty incredible, and then especially for older adults. So that's one of the successes that we've noticed in this program.
Yeah, thank you. So we know that Fit and Fallproof changes lives. Participants have reported anecdotally through success stories, through sitting down and talking with their leaders or health district coordinators. They've reported improved physical, mental, and I should also state through our evaluation, which we'll get to towards the end of these slides. They've reported improved physical, mental, and social health and wellness, increased stability, strength, energy, confidence. They enjoy the volunteer opportunities as leaders, opportunities for their own personal growth, and then as a site, hosting a site helps to build and foster communities. So we're also seeing specific sites within communities who are very interested in hosting this class because they know that it helps to build that community around the older adults in their community. We have just a couple of quotes, and I won't read these, but you can just see that taking this class has improved people from a physical, emotional, social perspective. So over the years, we've also received a lot of testimonials and success stories from our participants, from our leaders. These are just a few small examples, but we hear a lot of stories of participants that have exhausted their physical therapy benefits. Whether their physical therapist knew about this class or a peer knew about this class, they've joined the class and have continued to improve. And it's wonderful when we're able to hear that this class is just continuing that ability for somebody to maintain their health and well-being and improve after an injury. Some participants have also been referred by their physicians, something that we're working on currently, increasing physician referral, and that's helping to decrease their risk for falling. So we have a lot of Parkinson's patients in one of our local sites who are being referred by a particular physician in this region, and so we have 1 or 2 classes at a specific site that have more Parkinson's patients joining all the time, and it's been a great social outlet for them. Another example of another quote from a leader who's talking about the benefits of volunteering and the friendship that they formed, and she says it's a commitment you'll never regret, and is a very vocal advocate for the program, and is trying to get people word of mouth all the time coming to join.
Now I'll take it over for a couple of minutes and talk about the evaluation study. As I mentioned before, we've been collecting ongoing data since before 2012, but Boise State really started with 2012, keeping this ongoing data that we get from the different sites and the districts. But in 2014, we conducted an actual study so that we could gather data tracking participants at baseline and then seeing what happens over 10 weeks and then 20 weeks. And that's what this evaluation was about. I was part of a team doing that. And so we looked at the social, emotional, and physical outcomes of this program, tracking those, again, like I said, just join and seeing what happens. So I mentioned the purpose already, so I'll slide through that. So our methods, we recruited 120 new participants from 10 different sites, urban and rural. And we collected data at baseline at 10 weeks. And then for those that stayed on for a second 10-week session, we also collected their data. And 64% stayed on for the 20 weeks. The measures we used were a demographic survey. So at the beginning, we captured the typical demographics, gender, age, also chronic disease burden, how many chronic diseases did they have, did they use assistive devices, baseline time dumping those scores, and also an SF-36, which is a standardized, validated research tool that's used to measure, did we lose you? To measure physical, social, and emotional outcomes.
Looks like we've got some feedback if folks can remember to mute their phones.
Okay. All right, so the aim for time up and go, many of you might be familiar with this, but those that aren't, it's another validated measurement. And it's where it's the time taken to stand up out of a chair, walk 8 feet around a cone, and then sit back down. And it helps measure several different things: balance, gait, mobility, because there's a change in direction and getting up and out of a chair and then sitting back down. It also gives us a measure of strength. And so it's been used many times in research. Typically, it's the 10-foot up and go or the 3-meter. But in 1996, two researchers, Rickley and Jones, validated this for an 8-foot measurement, which is a little bit more applicable in a clinical setting or maybe somebody's living room where they don't have 10 feet. And so this is what Fit and Fallproof uses. So our demographics and our results, about 80% were female, which is slightly less than the typical Fit and Fallproof program. Usually it's about 85% female in most of the sites and 15% male. So we had slightly more males than typical, but it wasn't significantly different. Almost half had at least one chronic condition, and 37% had 3 or 4 chronic conditions, mostly arthritis and hypertension, which is kind of typical for this older adult population. The average age was 75 years old, and 16% use an assistive device, either a cane or a walker. So the results at baseline on the timed up and go, overall, there were significant improvements, especially between baseline and 10 weeks. And there continued to be improvements over the next 20 weeks, although not, or the next 10 weeks, although not as significant. There were still improvements, but it also shows how those improvements were maintained for those that continued on. This was interesting. We saw a dose-response relationship come out of this. Our statistician ran several different models, and what we found is, especially for those that attended 20 classes in a session, so went twice a week, those that were over 75 saw even greater improvements relatively than even the younger crowd. So this was really important to see that they saw improvements that were equivalent or greater than the younger participants. So just because somebody is older doesn't mean that they can't improve significantly. So that was a surprising and a wonderful response to see. So the SF-36, this reports things across several different domains relating to vitality, energy, social and mental functioning, and physical, and how those all interplay. 68% reported significant improvements. All these were significant improvements in physical function. 72% improved mentally, 85% in social functioning, and 72% in vitality, as it's reported on the SF-36. And there's an appendix at the end of this, at the end of the slides, for those of you that want to see it, they have more of the detailed descriptions and the significance of each of these domains. The most important finding, though, out of all of this And included in this post-survey was a 3-part open-ended question where participants could write in their own words the benefits they received and also things that they felt could be improved upon. The most common thing that they thought could be improved upon is they wanted more classes, so that was pretty much it. But the most important finding, the best benefit or the greatest benefit that everybody across the board reported was the social benefits. It was social and then exercise and then the instructors. But on the social benefits, we had comments like, I appreciate the social connection. It gets me out of the house. I have contact with people that I wouldn't get. I've made all sorts of new friends here. Just on and on, people were reporting that kind of thing. So we really see, while it's nice and it's very important to address the physical functioning and reduce fall risk that way, social isolation has been linked with increased fall risk. So this is just another way that there's a benefit to a prevention program like this. So limitations to our study, just briefly, we didn't ask for detailed medical histories or medications. That was kind of beyond the purview of the overall Fit and Fallproof program. Again, we're asking volunteers in a kind of an independent society like this. People don't always want to share that, and that's a lot of data to keep track of. So we didn't ask for that in the study because that's not part of the ongoing data collection. We wanted to have minimal disruption to the class. And again, we didn't track falls either. Typically in Idaho, hospitals aren't as ready to share that kind of information as other states. So without the ability to really get into the true rate of falling here in Idaho, other than what we have overall, just kind of general reporting, we didn't see how we could really link that back to the patients. So we didn't track falls specifically. And also self-reporting is not always reliable anyway. The SF-36 isn't completely useful for this population is what we found. While it's a wonderful tool and it's validated, some of the questions don't apply to this population. For example, one of the questions, how much does your physical functioning interfere with your ability to do vigorous activities such as running? So some of the responses that we got on this survey were, well, not at all. And then they would write a little note on the side, well, it's because I don't run, so they didn't know how to answer that, because then we see a couple of things, items down that they had difficult, climbing one flight of stairs, but they had no problem running because they don't run. Or how much does your physical functioning interfere with your ability to go to work? Well, most of this population is retired, and they would indicate that, well, I don't work, so it doesn't interfere at all. So I think it would be nice to have a validated research tool that's adapted to this older population. Otherwise, it's informative and useful, but there's just some questions that weren't completely applicable. So in summary, we saw results similar to studies that were conducted on programs such as Otago exercise program and enhanced fitness and some of those others that use maybe PTs or OTs. The TUG results that we saw mirror those to the ongoing Fit and Fallproof evaluation that we track. And so from session to session, we see significant improvements overall with the overall population in timed up and go scores, and we saw that here. And really, this is one of the few sustainable programs that use volunteer, peer-led leaders that's been going on. This is what, its 13th year that we're starting. The nice thing, too, is because it's in the community, class leaders live in the same communities as the participants. So each site has the flexibility to offer classes on the days and times that are convenient for the participants, rather than telling the participants, oh no, this is when you have to come. So it really has that flexibility to reach the needs of the community. And it demonstrates, again, this partnership between state and local public health organizations to bring those critical and effective fall prevention programming to rural and frontier communities. It really led to that sustainability. So the next steps, and this is where I'll hand it back over to Katie, because this is where we're going to be going next.
Thanks, Michelle. So next steps, we know falls don't, among our older population, do not only happen in the home. So we are doing some things to expand our borders beyond just an individual prevention-based fall prevention exercise program. So the first thing is looking at medical referrals. Many of our health districts, I believe 5 of the 7, are working on medical referrals with providers, clinics, and hospital systems. We are working on developing a prescription for fall prevention. That is one thing that, as we have asked and been working with our local health districts to go out and start connecting with providers in their community to refer their patients to this program, they've been asking, well, you know, besides the brochure, what can I give to my patient that, you know, such as a prescription, that will be more of kind of that, not incentive, but more of a, I guess, a valuable reason for them to go out and take that next step and join class. So we're looking at developing that prescription, working more on medical referral, and using CDC's. We're using our own materials as well as the CDC's study guide. It's a stopping elderly accidents, deaths, and injuries, and it's based on fall prevention in the clinical setting. So ensuring that they're screening for fall risks and referring to local community-based fall prevention exercise or fall prevention programs, making sure that they're checking their homes for fall risks. So that's been a really great tool for us to use in the medical setting. We're also working on walkability and focusing on walkability in the community. We actually have the great fortune of having Mr. Chris Danley and all the planning right here in Boise and in our Treasure Valley area. And so we have been working with Alta the last several years on improving walkability through workshops, through walking audits, in an effort to foster advocacy and support for older adults to be active in their communities. As an example, we will be working in an eastern Idaho community to make it easier for older adults to walk to local parks and improve the amenities within those parks. So we're looking at some different age-friendly parks tools and some different avenues that we can take to ensure that the places that are meant to be places of connection and socialization and activity in communities are truly friendly for older adults to be able to get there safely, for one, and be mobile, to get there in an active way, but also to, while they're there in that park, what amenities exist? Are there benches? Is there safe lighting? Is there safe surfaces? And those kind of things. So that state and local public health partnership is vital to the continuation of this program. We got done really fast, but are there, I guess we can take questions at this point.
Thank you, Katie. I appreciate it, and thank you, Michelle, as well. So with that, we have lots of time. I guess we can turn it over to any of the specific questions that folks who are watching might have. First question, we do in fact have one, and that is, do you get more funding because it is an evidence-based program?
You know, our specific funding through the Block Grant, no. PHHS is the Preventive Health and Health Services Block Grant. It is a grant that is administered to every state, tribe, and territories. There's, I'm going to get this number wrong, 62, I believe, grantees. The state of Idaho being one of those, we provide a continuing application on an annual basis. And because the block is it's legislatively funded, it's a legislative line item, so the funding actually comes down from Congress and then to DHHS and to CDC. So it's just dependent upon a formula. And right now, because the block is funded under the Prevention and Public Health Funds 100%, we got a bump in our funding when it moved over to the Prevention Fund the last couple of years. We're not really sure what that's going to look like moving forward, but right now it's really based on kind of a big funding of how much they decide to give to the block as a whole, and then how much the CDC has a formula based on what the original levels from 1981 when this block grant was originated, as well as population. So it's not based on if you're providing evidence-based programming, but really kind of a multiple, multifaceted funding formula.
All right. Next question. Was a difference noticed between improvements with a program that runs 2 times per week versus 3 times per week?
No, the results were very similar. Some of our sites do run 3 times per week, although the majority run twice a week. Really, it was based on how many classes they attend. So if they attended at least 2, they saw those results. What we do find in the general participant study, I don't know that we did this so much with our participants in the study, but in the overall participation, there are some that, because their site that's closest to their house meets twice a week, but they want to go a 3rd time, they'll go to another class somewhere else just so they can get that extra time. So really, it came down to how many classes. In some other studies in our literature review that we've been finding is going at least once a week, every week, you start seeing those benefits. But then twice a week is where we really saw those real significant improvements in TUG scores, especially for that older population, which really shows that they can improve a lot. But yeah, that's a really good question. We didn't have a big enough population of 3 times per week to keep the statistical power to separate that out. If we would have had a larger sample, we could have done that, I think. But overall, we see similar results.
Okay. Have you explored ways to modify the program to reach homebound seniors to help them exercise?
Not formally. Those were some of the things we've been discussing over the past couple of years of how do we extend this into those that are maybe more homebound. And we haven't quite gotten there yet. I don't know if Katie can speak to that, but those are some of the things that are on the radar.
One thing that we are starting just in this fiscal year is home fall safety checks. When we work with our local health districts, we provide a menu of activities which they can choose from. And so that was one of the new activities that we put on that menu this year. And we had several districts that selected working with a community partner to provide home fall safety checks. So this could be with individuals who are participants in the class, but it could also be, a random selection of older adults that may also happen to be homebound. So that is one way that we may be reaching individuals at home and assessing their environment for fall risks. But no, as far as the program itself, we have focused on the community setting and looking at the actual class and in places that seniors gather within the community rather than the individual basis at home. That said, we do have a DVD. So for seniors who may attend, any kind of an activity or event that is put on by their local health district, they're certainly able to grab a DVD and work out from their home. I believe it's on our website. If it's not, we'll make sure it's up there ASAP. But it is, I believe it's on YouTube. So there is access to an actual exercise program on a DVD or over the internet that we've developed here in Idaho.
All right. We actually have lots of questions for you since they're piling up. So is there a way to bring this program to other states? This particular person is in New York, where they say that they have all the evidence-based programs but would like non-evidence-based falls prevention classes as well.
Yeah, so that is a question we get a lot, and it's one that we're trying to work through the logistics of, because one of our main concerns is just ensuring the fidelity of this program as it is. Fit and Fallproof is trademarked, and so the information, the curriculum is public domain. It's funded through a federal grant, so it's public domain. It's available for anybody to take off of the web, but because we're trademarked, that's where the stickiness comes in. That said, we're very happy. I had a phone call with a gal in California just last month to talk about the program, and we have our 2 master trainers here that developed this curriculum, and so it would be something that would have to not probably be connected with us at the department, but with our master trainers themselves in terms of training individuals in other states. That's my take on it at this point, because we can't fund the program or support the program in other states with our federal and state dollars that we receive, but it would very likely be something where our local core master trainers would travel to that state, or somebody from that state travels in and is trained as a master trainer, and then you know, it's possible that there would be some kind of an agreement as far as adhering to the curriculum, adhering to the fidelity of the program, the trademark, etc. It's not out of the question. It's something that we've just been trying to mull over those logistics for quite some time.
All right. We actually have a good comment that Katie, you particularly probably would like to hear from Elvia Caldera Soria. I hope I got that right.
Oh, yeah.
She
yeah.
wants to congratulate you. He or I don't know Elvia, so apologize. worked in this program for 10 years and is dear to my heart, and I'm so proud of the opportunity this program has to present. I hope they keep getting funded. Probably a common sentence in a lot of ways right now.
Yeah.
Okay, is it feasible to combine this program with walking groups so that people still do the curriculum but get other times to walk together?
Yeah, that's a great question, and I would love to say that does happen in some of our districts where, or some of our regions where, you know, the classes really form a family, and the individuals, they check up on each other. When somebody is not at a class, somebody else always knows, oh, so-and-so is sick, or they have family in town, or, you know, somebody needs a ride. It's easy for them to find somebody who's willing to come and pick them up. I want to say during some of our regions, some of the sites have an off season, so they'll take time off in the summer because participation numbers tend to dwindle as individuals travel to visit family. They have family visiting them, so numbers typically are lower in our summer months. But that said, a lot of the classes will still meet and walk. And in fact, I want to say Elvia used to work in our Twin Falls Health District office, and in that region they even formed walking groups and have had groups that met. I know particularly the southeast and eastern Idaho where that has happened, and I think the idea is great. The more that we can get individuals moving, the better it is for them as far as their overall health and well-being. And that also has says a lot about our emphasis on looking at walkability and focusing on walkability for older adults in particular, and making sure that our environments are safe places that people can and want to go out and be active in.
And then, yeah, taking that, you know, one step further, if there was a site then that developed within that, a walking group, they could easily take the curriculum with them. Hey, let's walk to the park. Let's do these exercises outside of the park today because it's a beautiful day. And so it's very portable. That was the neat thing about this program. My first exposure was when I was introduced as part of the research team, and I've just stayed on with it since then because there's just nothing like it out there. And one of the benefits and the things that I think lends to sustainability is that it's portable. You can do these exercises really anywhere because you don't need specialized equipment. You know, there are some resistance bands that are used in some of the exercises, but a lot of it is body weight things, and that can be done anywhere. So it would be very easy to incorporate that into a walking group, and that could be the Fit and Fallproof class. Mm-hmm.
Yeah, and just to jump in on that, as Katie alluded to, have been helpful in some parts of this with respect to getting people to be able to feel comfortable enough in their own communities to walk to and from the sites themselves. And in other words, especially in a lot of the context throughout our state, pretty absurd if we feel like folks have to jump in a car to then drive, a couple of blocks. And so as part of that, we've been working with doing walk audit academies on how to train folks in those environments to audit those places themselves so that they can make improvements, so that they can do walking groups, or again just walking to and from the site. So it's quite a comprehensive program. One of the questions that has come up a couple of times, it looks like, has to do with training. So the one question is, could someone in another state become a master trainer, or how does one go about being trained in the program itself?
Yeah, and that kind of tags on with the question earlier from New York. Certainly not out of the question. I think it's something that we just need to sit down and kind of brainstorm how would that work and develop some procedures and a process around that coming from outside. We currently hold a contract with the core master trainers who develop the program. So it would need to be something that goes, I'm thinking, through them individually and not through us. We would certainly want to be included in that communication, but as far as their time, some kind of an agreement between that state or another entity and our core master trainers would have to be developed, because that's not something that we could support with our block grant or state dollars, because it would be leaving, essentially it's a program that would be leaving the state. But I'm definitely, it's something that we've been talking about and that we've had inquiries for as many, 9 years that I've been with the program. So not out of the question, and just something that we're still kind of looking at logistics of, but definitely worth a conversation.
Okay, do you have a screening process for participants?
No, there is part of the curriculum and the first day paperwork is they have to fill out a Part 2 and some basic information, emergency contact. And part of that Part 2 is, it's a standardized form that helps identify those that might need to get go see their doctor before they start an exercise program. They're not turned away, but they're strongly encouraged to get an okay from their doctor, which is kind of typical for any exercise program that they would go into. But otherwise, some of the programs that we look at, that we talked about, that are on the CDC compendium, there's restrictions, there's exclusion criteria. Well, you can't have Parkinson's, you can't have mental decline, you can't be in a wheelchair, you can't have all this. And yet in Fit and Fallproof, all of those are accepted. There are some who their caregivers bring them, or they've got Parkinson's, or they're in a wheelchair, or they're in a walker, and they're still able to do all those exercises because the curriculum, the class leaders are trained on how to adopt the exercises for different functional abilities. And so it's all inclusive, which is really great because everybody can get involved and be part of that and get moving, which is the point.
So we have a couple questions that are a bit related here. So can you provide more information about the differences between frontier and rural settings? And then, will the prescription for fall prevention for patients allow medical providers to be reimbursed for FP? I'm not sure if it's just, fall prevention, screening, and referrals, as well as provide cost coverage for patients. A couple of questions in there.
Yeah, that's what, so the prescription, as far as the reimbursement, that's going to depend, on the payers. We don't know where that's going to go yet. Right now, we're using the prescriptions more as to get the so it's more official. There's a movement in the medical community, and it's a trademark term. Exercise is medicine, so a doctor would prescribe using his prescription pad exercise for that patient, and so this is kind of a dovetail into that. So here's a prescription, and it looks more official, and the person's more likely to follow through. But the classes themselves are free, so the participants don't have to pay for it. So there's not any need for cost or help with the participant that's going to the class, so they don't have to pay for it already. And then the differences between rural and frontier has to do with the population density. It has to do with how many people per mile. And do you know those numbers off the top of your head? Rural is really spread out, or frontier is even more spread out. I used to know those numbers.
I want to say 7 persons per square mile in Frontier.
In Frontier, yeah. But it has to do with how many. I think it's even down to like 2 or 3 people per square mile in a Frontier. It's something. Well, less than 7. Okay.
Yeah. So I guess in Idaho, generally our population estimates show less than 7 persons per square mile in our frontier counties. Idaho as a whole, we mentioned this earlier, there's just under 16 people per square mile. And we go from rural to frontier to urban to suburban across our state. So just under 16 persons per square mile for Idaho population, whereas the U.S. averages about 80 persons per square mile. So it just shows you the difference in density in our state and just the land mass that we encompass. But yeah, no, that's a great question as far as the actual numbers for rural versus urban.
And just as a follow-up, and I think you touched on it, but just to make sure, so is Fit and Fallproof geared primarily for rural counties?
Oh, no.
No. Oh, go ahead.
Sure. So we have 117 sites. But the one that was my homework, and I neglected to get that done last week, was looking at the number, looking to see if the 117 or so sites that are currently running are located in each of our counties. And I want to say, if not, we're really close, but we have a great mixture. So where we're at here in Boise, Idaho, is kind of the population center. The greatest population in this valley in the state exists in this valley. So we have probably, I would say, close to 40 sites that are in the more urban area here. But of the 117 sites, probably roughly half of them, if maybe a little less than half, take place in our more rural communities.
Mm-hmm. And we see similar results across urban and rural as far as benefits to participants. So it's portable to either one, but it's geared really towards any place where seniors reside. It's not necessarily specifically for urban and rural. But it translates to either or. One of the things I didn't mention earlier is, there's a lot of areas or communities in the state that are unincorporated towns. 2 that stand out, Harvard and Princeton are 2 unincorporated towns. So they're tiny communities, and I looked at census data at the number of community dwellers, residents that are over 65, and there are Fit and Fallproof classes in those communities that have consistently, their attendance is even greater than the number of older adults in the community. And so it's getting people involved in exercise who wouldn't have any other opportunity, because there are no stepping on, there are no silver sneakers, because there are no gyms there. And so this is really, it shows the reach of this. It can go down to the tiniest community, as long as a community is willing to host a site, to the urban areas right here in Boise in this valley that has close to 600,000 people.
Yeah, and even our walk environment, our audits have been in very rural places like Fairfield, population of 400, all the way to some of the more urban environments as well. And so certainly the context change, which is actually quite fun. Couple questions here. Let's see. One is, this person coordinates a program called Stay Active and Independent for Life, which is a strength and balance exercise program. Their particular training requires candidates to have some type of fitness certification, such as Walk with Ease, before they can take the training and teach the class. So their question is, what are the prerequisites of your volunteer instructors?
That's a good question. So again, we're looking at volunteers they get the training at the one-day training class, and then the curriculum has exercises with descriptions on how to do it properly, and they get a lot of training that way. They also usually have been attending classes and learning the correct form, and they get ongoing training at refreshers. So they don't have to have a certification. We're not teaching to that level. We're teaching overall movement, but we do try to make sure they adhere to the fidelity of the program, which ensures safety. And then the 2 coordinators, key coordinators that develop this program are professionals in kinesiology and exercise science. And so the whole program is based on evidence and on proper form, but they themselves don't have to have a certification like from the American Council or an exercise or ACSM or any of those.
Yeah, and to tag on to that, for our master trainers, so Michelle mentioned our core master trainers, Jan and Terry Ann. They are the only two who are able to train master trainers, who then train our volunteer leaders. So to be a master trainer, there is some additional requirements. You know, they have to have some anatomy, physiology, some education, some definitely time as a volunteer with the program, or as a participant or a volunteer leader with the program. They have to know how the program works, obviously. And then they go through a more rigorous one-day training because what they do is they're training volunteer leaders, and so they need to know the curriculum at a much deeper level. So they go through a pretty one-day intense training with our core master trainers. They are then observed teaching a class leader training, and then they either receive the yay or nay by our two core master trainers. So, you know, if for whatever reason an individual is not passed during their observation, they really just take on as a volunteer class leader. They get some more time under their belt, and then they can go back and teach at the next volunteer leader training and be observed again. And, you know, they're given things to work on and to improve upon. And then they may be certified as a master trainer at that point. So there's that kind of difference in the hierarchy.
We have time for just a few more questions. One quick question is to clarify, can you please clarify the number of volunteers, whether or not Fit and Fallproof is a Tier 1 evidence-based program?
So we have more than 300 volunteers who are currently teaching classes or trained to lead classes throughout the state. So one of our goals is to have a team of leaders at each site so that it doesn't, the class does not weigh down on the shoulders of one individual to be there all the time. So that's why we kind of focus on a team of leaders. And I'm sorry, Chris, what was your second question? Tier 1. So we are actually working on that. So the evaluation that you heard in this presentation has actually been written into a journal article and submitted. What was the journal?
We're submitting it to the Journal of Gerontology. I forgot the whole title. I should have this right on the tip of my fingers. Yeah, it's getting ready to be submitted for a journal article. Once that happens, then you get to that Tier 1 rating once it's published. So we're close. Beautiful.
Okay.
5 years ago.
There you go. What are the expenses that a local site may have to implement this curriculum?
Yeah, so our formula has changed since I came on in 2008, but at the time, we did a rough estimate of about $3,000 per site, and that included oversight by our health district coordinator, as well as a site kit, time to train leaders, purchasing TheraBands, any other supplies. At the time, a lot of sites used, CDs with older music that would just kind of be played in the background. So there often was a CD player and some CDs in the site kits. Simple things like hand sanitizer, pens, clipboards. So just those basic materials plus the time and oversight from our health district coordinators. So we estimated about $3,000 per site. That's changed just with the way that our funding formulas have changed over the last several years, but I think that would be a pretty decent estimate to determine costs for getting a site up and going, promoting it, getting it out in newspapers or newsletters.
And that's kind of similar to what you'll see with some of the other programs. Enhanced fitness is probably the closest to Fit and Fallproof as far as the layout, the model. It's still different, but and their estimate to get a class going with training and everything is right around the same. So it's pretty consistent.
All right. Well, Katie, Michelle, thank you both for presenting today on the Fit and Fallproof class here in Idaho. I know there are a few questions that we weren't able to get to. I would encourage you who didn't have your questions answered to please feel free to reach out to Katie or Michelle. Their contact information is on the screen in front of you. Thank you, everybody, for attending today's webinar. Again, please do join our organization if you have time. Go to our website, sign up. We greatly would appreciate it, and we look forward to hosting future webinars in the future and near future, and we're excited, and thank you again for your time. Appreciate it.
Thank you for having us.
Thanks.